Welcome to the Bladder Cancer Sick Group webinar. This is the first webinar we have this year in 2022, and we are so excited that we finally have been able to present an outstanding panel of speakers who will try to enlighten you on improving psychosocial care of patients with bladder cancer. And the panel consists of Professor Nihal Mohammed, who is a professor at Health Psychology and Behavioral Science and a director of Health Disparity Research in the Department of Urology at Mount Sinai Hospital in New York. The second speaker will be Beth Russell, who is a postdoctoral cancer epidemiologist at King's College in London. And she has working at the Guy's Hospital World, I think is called World Cancer Evidence Program. And she's now working with bladder cancer since she's finished her PhD in 2020. The third speaker is Anna Hare, who is a clinical trial coordinator from King's College as well. And she's starting her PhD study. I don't know if you already started, Anne, but you would like to evaluate the impact of bladder cancer diagnosis on patients' mental well-being. The other panel is Dr. Elke Rahman, who is a postdoc researcher from Ghent University Hospital, and she has been one of the pioneers, I must say, to put psychosocial care in patients on the agenda of bladder cancer. And finally, we have Line Noos from Copenhagen University Hospital, and she's also a PhD student, and she's investigating prehabilitation as a method for risk reduction in urethral cancer surgery. So we have 5 excellent speakers this evening. So this is the program in short. So you can see there's each speaker will do their talks in this, like it's scheduled here. And if you have questions, you can write it in the Q&A section, and we will take all the questions by the end of the whole session. As you know, this webinar will be accredited with 1 CNE credit upon completion of the questionnaire after attending this webinar. And finally, you should notice that you will receive an email the following day with more information so you can get your credit. But first of all, we will start with Nihal Mohammed, who give a talk about what are the unmet needs in psychosocial care in bladder cancer patients. So have a good evening. You may share your slides.
Hi, everyone, and thank you, Dr. Jensen, for the amazing introduction. It's been an honor and a pleasure to join the panel today, and I look forward to your input and comments on this presentation. Here is my disclosure statement. As we all know, bladder cancer is one of the most common cancers globally, and in the US, it's expected that about 82,000 new cases in this year alone. The disease has some implications based on the age and gender of patients, as we see it more commonly diagnosed among male as compared to female, and among older patients as compared to younger patients. We have also observed some indicators of health disparities in the US based on the racial background, gender, and age, with Black American, women, and older patients experiencing worse outcomes and higher aggressive disease rates as compared to their counterparts. Drivers of these disparities may include lack of education about the risk factors of bladder cancer, limited access to healthcare, and coexisting comorbidities, specifically among older patients and minority patients in the US. Both bladder cancer diagnosis and treatment outcomes are associated with higher psychological distress. Unfortunately, prior research examining these aspects in bladder cancer patients are scarce. So the aim of this presentation today is to assess psychological distress symptomatology measured by the hospital anxiety and depression scale among bladder cancer survivors, and also to explore what clinical, demographic, and psychosocial characteristics of these patients, including existing supportive care needs and perceived social support, could predict anxiety, depression, or even HATS total score. So our research question and the research study design was guided by the transactional model of stress and coping that hypothesized that during or at time when individuals are confronted by stressful events and when the demands associated with that specific event exceed their resources, including social support or self-efficacy or coping strategies, they're likely to experience higher unmet needs, which in turn may lead to worse patient psychological adjustment and well-being, and vice versa. So to examine our major question regarding the level of psychological distress symptomatology experienced by bladder cancer patients, we conducted a qualitative study back in 2014 examining patients' unmet needs, including psychosocial care-related unmet needs. So about 30 patients participated in this study, and when we asked them about the type of unmet needs they experienced across the disease trajectory, including the time of diagnosis, after surgery, and during survivorship, participants reported different kinds of unmet needs around the need of information about treatment option and side effects at time of diagnosis, in addition to depression and cancer-related worries at that time too. After surgery, needs revolved around medical issues such as need for support with pain, and also how to use stomal appliances and catheters, and additional needs reported around financial support. During survivorship, different sets of unmet needs emerged, including needs for psychological support with depression, body image change, and other social related needs such as adjusting to the new life or going back to work or traveling. So learning from that experience that we received or information we received from conducting the qualitative assessment, we decided to conduct an online quantitative study based survey that could provide some sort of information to quantify the association between psychological distress and its predictors. So we recruited about 159 bladder cancer survivors from the Bladder Cancer Advocacy Network back in December 2014 and provided different measures to assess psychological distress, including the hospital anxiety and depression scale, the bladder cancer need assessment survey that we specifically developed at that time to assess different unmet needs related to the bladder cancer experience, in addition to the social support or social provision scale. So about 159 survivors participated in the study, and as you see here, the majority were male with partners, have higher education, were medically insured, and were employed at the time of the assessment. In addition to that, the majority were diagnosed with muscle-invasive bladder cancer and received cystectomy as their major treatment. So the descriptive data analysis of patients' responses to the hospital anxiety and depression scale showed that about 25% of these survivors reported clinically significant levels of anxiety at that time, and about 17% reported clinically significant levels of depression at that time. Unmet needs that range from moderate to high unmet needs range from different domains of needs, including the psychological needs, the health system related needs, physical and daily living, sexuality, and communication related needs. Although these participants, if you look at the social support indicators, reported moderate levels of social support across different dimensions, including attachment, social integration, reliable alliance, and guidance, that should have buffered the impact of bladder cancer on anxiety and depression. So in order to analyze the associations between patients' demographic and clinical characteristics and depression, anxiety, and HADS total score, we conducted univariate analysis to explore what exactly predicts these dimensions. And as you see here, anxiety, depression, and HADS total scores were associated significantly with older age and lower educational level. When we also conducted linear regression models with all the unmet needs categories and the social support subscales we examined, controlling for age and education level, as you see here, physical and daily living needs and sexuality needs emerge as significant predictors of anxiety, depression, and HADS total score. Regarding the social support, three major significant indicators of the social support subscales, including social integration, reliable alliance, and guidance, emerged. A stepwise linear regression analysis using the selected predictors based on the previous regression models that I showed you revealed that age continued to be a significant predictor of anxiety and HADS total score, and that physical and daily living needs and sexuality needs remain significant predictors of anxiety and HADS total score, in addition to the depression score in the case of the physical and daily living unmet needs. In addition to that, guidance and reliable alliance remain to be a significant predictors of HADS total score, anxiety score, and depression score. So in conclusion, a significant proportion of bladder cancer patients experience clinically significant levels of anxiety and depression requiring psychological interventions. High to moderate unmet needs are commonly reported by survivors across different domains of unmet needs, in spite of the moderate level of social support reported by these participants. So the results that we have seen from the regression analysis indicate that interventions should be or could be tailored to patient-specific characteristics, whether it's age or educational level, or the type of social support received, in order to provide the needed psychological support that could buffer the impact of bladder cancer on patients' quality of life and outcomes. I'll stop here because of the time, but I am happy to answer any questions you might have. Just want to say thank you to the audience, and thanks to my research team, my research coordinator, and the general support of the NIH that helped me with this study. Thank you.
Thank you so much, Nihal. We saved the questions to the end of this seminar. And all, please write in the Q&A all the questions you may have for Dr. Nihal Mohammed. Thank you. The next speaker will be Elke Rahman from Ghent in Belgium. Will you share your slides?
Okay. Good evening, everyone, and thank you very much. Also, Dr. Jensen, from my side, many thanks for having me here. I can share our results with all of you tonight. So the title of my presentation will be Psychosocial Care for Bladder Cancer Patients Undergoing Radical Hysterectomy. First, I will show you some results about a longitudinal study that we conducted on the supportive care needs of bladder cancer patients. And then in the second part, I will go more into depth about what the supportive roles are of the healthcare professionals. I have no conflict of interest. So a short introduction. I'm sure everyone is familiar with the bladder cancer population, but as a short background, so bladder cancer is the 9th most common cancer worldwide. 75% of the patients diagnosed are men, 25% are women, and it's a disease most common in the elderly. Muscle invasive bladder cancer has a significant burden on the patients. So muscle invasive bladder cancer is treated with chemotherapy, radical hysterectomy, a new urinary diversion, or bladder sparing therapy, radiochemotherapy. And all those treatments have different side effects. So the most common side effects in this population are urinary, gastrointestinal, and sexual dysfunctions, but also disruptions in social interactions, body image, and a decrease in emotional functioning. Moreover, we see, like a recent study showed that the bladder cancer experience is worse compared to experiences in other populations, and people undergoing radical hysterectomy have a higher suicide risk compared to other tumor groups. So in order to address those physical but also psychosocial side effects, we need supportive care to address those side effects. And supportive care is care given to patients to improve their quality of life. And so the goal of supportive care is to prevent or treat as early as possible the symptoms of a disease. And supportive care consists of different interventions. You can have exercise, psychosocial care, nutrition, smoking cessation, but today I will focus on psychosocial support. So if we look into the literature about the evidence of psychosocial interventions in the general cancer population, then we see that psychosocial interventions have positive effects on psychological distress, health-related quality of life. It helps people to deal with changes in their lives, their mood, and also it helps people to adapt to their cancer and to their new life. But then first we had a look what's the evidence in bladder cancer patients for psychosocial interventions. So we performed a systematic review to summarize the evidence. There were only, so this study dates from 2017, but back then there were only 3 psychosocial studies, and the psychosocial interventions showed positive effects on anxiety, depression, general health-related quality of life, and fatigue. However, the studies had small sample sizes. There was a lot of heterogeneity in the interventions, and the study quality was low, and 2 studies also dated from more than 20 years ago. So recommendations based on that systematic review. So interventions should be tailored to the specific needs and wishes of patients, but also more prospective data was needed to assess their needs and wishes, and also research about the taboo around psychosocial support or how to address patients' needs was needed. So that brings us to the first study that we conducted. So we used a longitudinal cohort study in 90 patients from Ghent University in Belgium. And so we assessed the unmet supportive care needs and also the current use of supportive care among bladder cancer patients undergoing radical cystectomy. We used supportive care needs survey short form 34 and also some ad hoc questions about the use of supportive care. We assessed we collected data on 5 different time points before cystectomy, and then 1, 3, 6, and 12 months after cystectomy. So the majority of patients reported at least one moderate or high supportive care need across all time points. So before radical cystectomy, 82% reported at least one moderate or high supportive care need. At month 1, it was 84, then 86, 64, and 60%. If we then look more into depth into this the kind of supportive care needs, then we see that psychological, informational, and physical needs were most common across all time points. But now we only see a value between 0 and 100, which doesn't really say much. So we compared our data with reference data from this questionnaire. And then we see that across all domains, our data showed worse results compared to data in other tumor groups from those reference data. So for the psychological needs, the reference data showed 20.9, and our value was 26.5. And so for all domains, we see the same trend that bladder cancer patients, or at least the patients in our cohort, showed worse results compared to the reference data. So and in the preoperative phase, it's the psychological and the informational needs which were most common. And then in the postoperative phase, we see that the physical and informational needs become most common, but also psychological needs are still high across all time points. So this is just an overview of the top 5 unmet supportive care needs across all time points, and we see that those supportive care needs most common across all time points are uncertainty about the future, fears about the cancer spreading, lack of energy, tiredness. So I'm not going to go through all needs now, but we see those 3: uncertainty about the future, fears about cancer spreading, and lack of energy are most common across all time points. But then if we have a look at the use of supportive care services, then we see that the majority of patients don't use supportive care services. Some patients go to a psychologist, dietitian, but this is just the minority. Patients also indicated that the use of supportive care services was not discussed during clinical consultations, but they also didn't found it a shortcoming. The majority of patients did not wish to talk about their problems to someone, but if they wanted to talk to someone, they indicated they preferred their physician for more information. So this brings us to the next question. Because we see they have a lot of supportive care needs, but they don't use supportive care services. So how do we address the needs of bladder cancer patients? In order to address this question, we conducted a qualitative study. So where we also wanted to have a look at what the patient's perspective is about the different roles of the healthcare providers. And so, qualitative research design, we performed 16 interviews. We used a cyclic process of data collection and analysis. Interviews were audio taped and transcribed, and we used in vivo to conduct our thematic analysis. Information was the most important theme across all interviews. Information is key in the bladder cancer pathway because patients describe that information can help them in the shared decision-making process to cope with their cancer. Also, information is very important to reduce mental distress. So a lot of patients said, had mental distress, psychosocial issues, but they say that they, in order to address this, they don't expect that going to a psychologist or talking about their problems will help them. They say that information is actually the first step to reduce mental distress. And information is also key in the post-operative phase to help patients with their self-management for their new urinary diversion. The most important healthcare professionals or significant others during the bladder cancer pathway were the clinical nurse specialists, the urologists, the general practitioner, peers, and family members. So this is just an overview of which healthcare professionals can help at which time point. This is to address more informational needs. So, for example, if we look at the general practitioner is already important before the diagnosis to in order to refer the patient to the urology department. But then the GP also has a significant role between diagnosis and their cystectomy to clarify medical terms, to support patients in their treatment decision making. And then if we look at the role of the GP after radical cystectomy, patients wanted to talk to their GP about their problems that they experienced, but they found it sometimes hard because they found that general practitioners often have a lack of knowledge about the specific types of urinary diversions. So this was just an example. I'm not going to go through all the text at this slide, but the study is published. So if you want to have a look at it, please do. Then how do we address emotional support? So the healthcare professionals that I addressed in the previous slides, so were physicians, which were most often the urologists, and the urologist is important to deliver important information to the patient, but it's important that there is open communication, that they have the feeling that the physician takes time during clinical consultations, and also that he or she is prepared for clinical consultations. And then the clinical nurse specialist, the information provided by the nurse specialist reduces emotional stress because, and also the nurse specialist is seen as the first and also a fixed and first contact person during the whole bladder cancer pathway. So this was really a very important person for bladder cancer patients. Also, patients found it important that they have the feeling that there is good communication between the hospital staff. This makes them feel safe. And then partners, or of course, or other family members, very important because there is already a relation of trust in place, and it's important to take their partner with them to the clinical consultation. However, sometimes the partner or the other family members can also have emotional difficulties, and so there should also be attention to the partner or the other family members, and not only focus on the patient. Then peer support is key. I think clinical nurse specialist and peer support were the two most often described themes across all interviews. It's important to exchange experiences with peers. However, there were also a few patients that didn't want to talk to peers because they didn't want to hear about negative experiences. So you have, most people found it important, but there is also a counterpart. And then if we speak about emotional support, we often think about psychosocial care services, psychologists, but the majority did not want to go to a psychologist, and several barriers were indicated for this. So I'm just going to give you an overview of all the barriers that were reported. So people sometimes often just didn't know about the role of a psychologist, what a psychologist would mean for them. They had a will to be independent and have control over their own life. Also, it's hard to, psychologists should introduce themselves. It's hard to ask for help themselves. So it's much easier if people are hospitalized, for example, that the psychologist just go to the room and that the patient don't have to ask for help themselves. No connection with a psychologist was also a barrier. Negative experiences in the past made them strong. For example, a divorce or something else that happened in their lives. And then they said, I'm strong. I had a lot of, I went through a lot in my past. So I think I don't need to go to a psychologist. Negative experiences with psychologists in the past. Sometimes patients said cancer is a physical condition that only needs medical help. If their physician or general practitioner does not advise to go to a psychologist, then that was enough. If the physician should say you should go to a psychologist, and sometimes then sometimes people said, yeah, then maybe I would have gone to a psychologist. And people also have the will to optimistic. And there are also some perceptions about psychologists that patients have. They think that psychologists focus only on the negative things, that they cannot change their situation, that they treat you as a number, and that it is not the same as talking with loved ones. And they also think that psychologists only treat patients that cry the whole time. However, there were only 2 patients in our cohort that did go to a psychologist, and from their perspective, psychologists could help them to deal with their new urinary diversion. They also found it helpful to realize that you're still able to do something. So psychologists could help them to realize that, focus on the things that they are still capable of doing. They thought it was valuable to express their feelings to someone who is not family. They also thought they were not being judged, and talking to someone who has experience with other bladder cancer patients was also indicated as a valuable asset. So recommendations now based on both studies, that there is a need for educational interventions. Education information is key in the bladder cancer pathway, and especially in the decision-making process and in the post-operative self-management period. And then also social support should be mobilized, and especially the role of the clinical nurse specialist should be optimized, because he or she is a very important person to provide information and to support the patients. And then we should also implement peers in the clinical pathway, implement peer support in the clinical pathway, because this was also seen as very important. We should also develop and implement tools to improve communication between patient and physicians. For example, implementing prompts in clinical practice might be a valuable tool in order to improve this communication. And we should also try to find ways to increase bladder cancer specific knowledge in general practitioners, or at least provide general practitioners with bladder cancer specific information in case they have patients with bladder cancer. So it would be good if they just have easily access to sources with that information. Okay, this was my slide for the Q&A, but I think we keep that for the end. Thank you very much for listening, and I welcome any further questions at the end of this webinar.
Thank you so much, Elke. So that was the recipe. Now we know that. All right, we will continue with Anna here. She will give us a talk about the effect of cancer diagnosis on mental health well-being. Go ahead, Anna.
Hi everyone, thanks for listening to my talk today. I'm going to give a brief discussion of the effect of a bladder cancer diagnosis on a patient's mental well-being. I have no conflicts of interest to report. So today I'm going to discuss the interplay between bladder cancer and mental well-being, and then I'll give an overview of the collaboration between Guy's and St Thomas's NHS Foundation Trust and the South London and Maudsley Mental Health Trust, which has created the patient cohort for this study. And then I'll go on to the specific project, which is identifying the risk factors associated with patients developing severe mental health disorders following a diagnosis of bladder cancer. I'll give a brief summary of the bladder cancer incidence in the UK, which I'm sure is familiar to some of you on this talk. So bladder cancer is currently the 11th most common cancer in the UK, accounting for 3% of all new cancer cases. In 2019, the incidence rates in the UK for all bladder cancer stages were 31.7 per 100,000. And this can be categorized further down into non-muscle invasive bladder cancer, which was 22 per 100,000, and muscle invasive bladder cancer, which was 5.8 per 100,000. It should be noted this is for urothelial carcinoma with stages known and does not include metastatic bladder cancer, as these statistics are not yet available. To the right, you can see the diagram explaining all the BC stages. As I'm sure some of you know, non-muscle invasive bladder cancer is categorized as TA, T1 and CIS disease on pathology. Non-muscle invasive bladder cancer, sorry. Muscle invasive bladder cancer is classed as T2, T3 and T4 on pathology. And then the N and M stages define nodal and metastatic disease. So the diagnosis of cancer and its subsequent treatments have a significant psychological and emotional burden on patients. Higher levels of anxiety and major depression are reported by cancer patients compared to the general population, as we've heard in the other talks. And in particular, bladder cancer patients frequently report poor emotional and mental health outcomes. There's evidence from multiple studies looking across the stages of bladder cancer that shows this diagnosis of bladder cancer coexists with a diagnosis of depression and anxiety. And at this diagnosis time point, patients often report a decline in their mental, emotional, and social quality of life through the standardized questionnaires, and they often report significant psychological distress to their treating physicians. There are limited studies looking at this specifically for non-muscle invasive bladder cancer, but the studies that do exist show that this decrease in mental well-being can be only associated with the diagnosis itself and could improve over time, particularly following successful TURBT. A large amount of literature does exist for muscle invasive bladder cancer patients, which predominantly focuses on patients who have radical cystectomies. Although some studies do show this improvement in depression and anxiety scores in the months after their diagnosis, particularly if they have successful treatment and a good physical recovery, other studies shown that this poor mental health can continue even up to a year post radical cystectomy, as the other two talks have also touched on. This is often specifically related to symptom and treatment-induced distress. For example, radical cystectomy can leave patients with significant body image problems and can affect their sexual function. If they've had radiotherapy, they can have continued urinary and bowel symptoms as side effects, and this could all contribute to continuing depression and anxiety. There is also an increasing amount of evidence that shows a diagnosis of bladder cancer can also lead to the development of a mental health disorder, rather than just poor emotional and mental well-being specifically related to that time of diagnosis and treatment. Unfortunately, this has also been shown to lead to increased suicide rates in bladder cancer patients. A recent UK-based study showed that there is in fact an increased risk of suicide for bladder cancer patients compared to the general population and also compared to the other cancer types. In this national cohort study, the research team from the University of Birmingham identified all patients diagnosed with cancer in England and Wales between 2001 and 2011 and matched it to patients who had an ICD code for suicide. And this created a retrospective cohort of 980,000 patients diagnosed with cancer. This showed that patients with urological malignancies are 5 times more likely to commit suicide than the general population. And in fact, of all cancer type, bladder cancer had the highest risk. The suicide rate was 48 per 100,000 compared to 30 per 100,000 for all cancer suicide. This has also recently been confirmed in a cohort of US cancer patients that noted that male patients, single, of the older age and with more advanced disease were particularly at risk of suicide following a diagnosis of bladder cancer. This 2018 UK data was presented at the EAU meeting in Copenhagen in 2018, and it provided that key evidence linking bladder cancer and the development of a severe mental health disorder in the UK. And this was the trigger for our research team at King's College London becoming involved in researching the interaction between mental health and bladder cancer. So the previous slides show that it's recognised that some patients may develop a significant mental health disorder following a diagnosis of bladder cancer, which can potentially lead to suicide in some patients. However, there are still very limited studies looking into specific interventions designed to address this. We do need these interventions because poor mental health in bladder cancer patients has been shown to negatively impact treatment and survival outcomes. Therefore, it's essential to first understand the prevalence of these serious mental health disorders in bladder cancer patients at their time of diagnosis to then help inform the design of these interventions. To do this, a collaboration between Guy's and St Thomas's NHS Foundation Trust and the South London and the Maudsley Mental Health Trust was set up to determine the prevalence of mental health disorder in our local bladder cancer population. So the bladder cancer team at Guy's and St Thomas's Hospital diagnoses, treats and provides follow-up for bladder cancer patients in 6 South East London boroughs and does also accept referrals from tertiary centres. The South London and the Maudsley hospitals, also known as SLAM, provide mental health services in the same catchment area. We worked closely with the data analytics team at the SLAM, who provided us with a list of their patients who had also had a diagnosis of bladder cancer from Guy's Hospital. We did this matching on anonymised NHS numbers to protect the identity of these patients and looked at a time period of between 2006 and 2018, which generated a cohort of 155 patients. As you can see from this diagram, this included patients who had a mental health disorder diagnosed before the diagnosis of bladder cancer, and then 44 patients who were diagnosed with a mental health disorder after they were diagnosed with bladder cancer. Following the linkage of these two databases, we were able to collect the following data. So demographics, which included date of birth, sex, ethnicity, marital status, smoking status, and number of comorbidities, and date of death, and the cancer data, which included the date of cancer diagnosis, a histology subtype, the TNM score, which gave us the bladder cancer stage, what treatments they had, and if the patients had any recurrence. So these demographics and cancer data were collected from the GSTT patient records, and then the mental health data was provided to us by the SLAM analytics team, and this included the date of the mental health disorder diagnosis and the type of mental health disorder a patient received. You can see in the table below the types of mental health disorders experienced by patients diagnosed with bladder cancer at GSTT, and this includes substance abuse, depression, phobias, and other anxiety disorders. Once we had set up this cohort, I was able to start the first project, which was identifying the risk factors associated with developing severe mental health disorder compared to mild, moderate mental health disorder after a diagnosis of bladder cancer. I was particularly keen to start in this area, following the statistics about bladder cancer patients being more likely to commit suicide than other cancer types, as I thought it would be important to see if we could identify what risk factors meant that some patients developed that severe mental health disorder compared to mild, moderate mental health disorders. So we included all patients who were diagnosed with a mental health disorder after they received a diagnosis of bladder cancer, which created a study cohort of 44 patients, as you can see below. For exposures, we looked at the bladder cancer type at diagnosis, which we categorized into non-muscle invasive bladder cancer, muscle invasive bladder cancer, and metastatic bladder cancer based on the TNM scoring. And we also looked at whether sex, age, ethnicity, and number of comorbidities were relevant risk factors. Our outcome was a diagnosis of severe mental health disorder versus mild moderate mental health disorder, and we categorized these mental health disorders based on the ICD codes provided by the SLAM. Here you can see my table 1 that gives you an overview of the characteristics of the cohort. The first 2 columns show the number and frequency of each of the characteristics within the total cohort. So the total cohort is smaller, only 44 patients, but we can see that it is generally representative of the UK bladder cancer population. For example, the non-muscle invasive bladder cancer patients account for about 2/3 of this cohort, and the male patients also account for about 2/3. The mean age is slightly younger than what we expect in the UK, where the mean age at diagnosis is 73. And then you can see that I've categorized the patient's characteristics and stratified by severity of the mental health disorder. And there are some interesting factors to note that, in fact, the frequency of patients with non-muscle invasive bladder cancer and muscle invasive bladder cancer remains very similar in the mild, moderate, and severe categories. So there isn't a much larger number of patients in the severe mental health disorder with muscle invasive bladder cancer. Interestingly, in the severe mental health disorder category, 90% of the patients are men. This does somewhat support what the US cohort study found, with men being more likely to commit suicide following a diagnosis of bladder cancer. But again, as this is a small cohort size, it's quite hard to generalize. And again, the mean age in the severe mental health disorder category is slightly younger than the mild moderate category and slightly younger than what we would expect for a bladder cancer population. Next, I performed a logistic regression, and this DAG diagram just shows you all the variables that we included. And these are my results. So the odds ratios were calculated for each exposure, and this tells you the measure of association between the exposure and the patient developing severe mental health disorder. As you can see, I looked at whether bladder cancer type is associated using non-muscle invasive bladder cancer as the reference value. For sex, female was used as the reference value, and for age, less than 50 was used as the reference value. And as you can see, there was no significance in the 95% confidence limits for any of these exposures. So this tells you that we cannot say that any of these exposures are risk factors for severe mental health disorder. This is the next table of results, where I also looked at smoking and comorbidities. Again, never smokers were used as the reference, and 0 comorbidities were used as the reference here. And again, you can see that none of these odds ratios were significant at the 95% confidence limits, so we cannot say that any of these exposures can be seen as risk factors for severe mental health disorder. So in conclusion, there are no specific risk factors associated with the development of a severe mental health disorder following a diagnosis of bladder cancer. A holistic approach is therefore needed to support bladder cancer patients after their diagnosis, which is not specific to their individual patient characteristics. Our next plan is to investigate if there are any risk factors for bladder cancer patients in developing any type of mental health disorder following their bladder cancer diagnosis, independent of the severity of mental health disorder they are diagnosed with. And for this, we'll use a matched cohort of bladder cancer patients from GSDT who received a bladder cancer diagnosis in the same time period as this study and did not go on to develop a mental health disorder. Further work that we hope to continue with is to determine if the development of a mental health disorder following the bladder cancer diagnosis affects the cancer treatment a patient receives. And then, because of the other element of the cohort we have, we would like to investigate the patients who had a mental health disorder diagnosed before their cancer diagnosis and see if this mental health disorder diagnosis impacted the stage of bladder cancer patients are diagnosed with, and to see if it affected the cancer treatment they received in any way. Thanks very much for listening.
Thank you so much, Anna. Very interesting. There must be a lot of questions for this. Shocking with the amount of suicides. I mean, this is really an eye-opener, I suppose. We go on anyways with the next speaker is Beth Russell, who will talk about designing a pragmatic intervention to help improve the BC patient's experience. Go ahead, Beth.
Thank you, Bente. So hi, I'm going to be presenting this project today, designing a wellbeing intervention for bladder cancer patients. So I'm presenting this, so this work was done by Dr. Agustina Besser as part of her PhD. So she's now graduated, so I'm presenting this on her behalf. So I've got no conflicts of interest. So why did we look at wellbeing in bladder cancer? And obviously it's been discussed already quite a lot this evening, but we all know that bladder cancer is a very common cancer. But despite it being a common cancer, there is evidence to suggest that bladder cancer patients have a worse patient experience than other cancer patients. One element of this patient experience is health-related quality of life, and a related concept to this is well-being, which is to do with positive aspects of a patient's life. So there is a real need for wellbeing programs to be developed specifically for bladder cancer patients. So the aim of this project was to develop a wellbeing intervention which can hopefully increase the patient awareness and adherence to the already available services and can better support their needs and improving health-related quality of life. So this project consisted of 3 phases, but itself was the first phase of the MRC framework for developing complex interventions. So development being the first phase, and then the other phases are implementation, evaluation, and feasibility. So we just looked at the development part here, and we split it into 3 more phases. So phase 1 was identifying the existing and relevant literature. Phase 2 was a consultation phase in which we conducted discussion groups. And then phase 3 was the designing of the actual feasibility trial. So phase 1, identifying existing and relevant literature. So we decided to split the wellbeing into 3 different sections. So we looked at mental wellbeing, sexual wellbeing, and physical wellbeing. And we wanted to answer 3 specific research questions. The first one was, what mental wellbeing interventions are the most beneficial? What are the needs of patients regarding sexual wellbeing? And also, is there a need for exercise intervention in the bladder cancer patient pathway? So in order to answer these research questions, we conducted 3 different systematic reviews, and I'm just going to sort of give a brief overview of each of the reviews. So the first one was looking at sexual wellbeing in bladder cancer patients. So we identified 37 studies for the review, and most of these were looking at muscle invasive patients specifically. Unsurprisingly, radical hysterectomy was found to be associated with negative feelings for bladder cancer patients regarding their body image, whereas patients who had undergone a bladder sparing technique actually had a better perception of their body image and consequently had an overall better sexual well-being. There was a real heterogeneity in the measurements that were used for sexual health, and also, even though it was identified in the review, there was a need for inclusion of psychometric measurements. Lots of studies actually failed to do this. In terms of mental well-being, we wanted to look at what mental well-being interventions already existed for bladder cancer. So when the search was run for this, there was actually no results. So we decided to run the search instead for all urological cancers. Only 10 studies were included in this. Most of them were in prostate cancer and 1 was in kidney cancer. In terms of the endpoints, depression was the most commonly reported endpoints. And like the sexual wellbeing systematic review, there was also a variety of assessment tools used. In terms of the actual intervention, the couples intervention seemed to be the most feasible and acceptable. However, there was obviously a real paucity of feasible and acceptable interventions for bladder cancer patients specifically. The physical wellbeing review was conducted as a scoping review. And this included 14 studies with a variety of randomized control trials, some cohort studies, questionnaires, and a couple of interviews. Overall, there's a real lack of consensus on the physical activity intervention for better outcomes for the bladder cancer patients. There did seem to be some preoperative physical activity interventions that were feasible and acceptable. However, lots of the studies only really looked at the short-term effects, and the long-term effects of these interventions are still quite unknown. The main sort of questions that came out from this review were so which patients would benefit most from different physical activity interventions, what should the actual intervention look like, when should these patients be doing it, so especially if patients have undergone surgery, when is it safe for these patients to have the physical activity intervention, and also how long, so how long should they continue to do this. So phase 2 of designing the intervention, where we conducted 5 discussion groups. We looked at, so we did 2 discussion groups for the mental well-being and also 2 for sexual well-being. And this was because there were quite sort of distinct patient groups that we wanted to stratify by. So for the mental well-being, we looked at non-muscle invasive and then muscle invasive separately. For the sexual well-being, we looked at men and women separately. And then we did 1 overall discussion group for physical well-being. So this is just some sort of take-home messages from the different discussion groups. So for sexual well-being, it's also worth noting that these were patients identified locally at our hospital, Guy's Hospital. So the men felt well supported. We think this is probably because the men have an erectile dysfunction clinic which they can go to. So overall, the men felt quite well supported in this aspect. However, women did say that there was a lack of information available for them. They found it quite hard to talk to their clinical teams about it. And also, unsurprisingly, surgery had a big impact on the sexual well-being of bladder cancer patients. For the mental well-being discussion groups, the biggest impact seemed to be on the muscle invasive patients, and particularly at diagnosis seemed to be when there was a sort of immediate impact or biggest impact on these patients. For the non-muscle invasive group, there tends to be a bit more anxiety around sort of progression of disease and potentially needing sort of further treatment down the line. The patients expressed sort of a need that information need to be delivered in a timely manner, that support from their family and friends was imperative, and that actually it'd be really useful to have someone to call, whether this be a nurse in urology or a mental health nurse, to talk about their mental well-being. The physical well-being discussion group was fairly positive, and actually most said that they already undertook some sort of physical activity. They said there was a real preference for group activities, but they really did require support, and actually there was a bit of a lack of information about maybe when physical activity was safe, particularly if the patient had undergone surgery. So phase 3 was actually designing the feasibility trial. So we've decided to run this using the Graham-Roberts study, which is a study we run at Guy's Hospital, where all patients who are newly diagnosed with bladder cancer or are diagnosed with recurrence are eligible to be consented. And we run this as a trial, hope to run it as a trial within cohorts. So the benefit of doing this is that those who are allocated to the intervention arm are the ones who have to re-consent into the study. So when patients consent into the Graham-Roberts study, they consent to be a control in whichever trial we then may run. So this sort of eliminates any contamination. And it means that we can compare the wellbeing intervention with the standard of care for the bladder cancer patients. So we want to include 40 patients at a 1-to-1 ratio, so 20 patients in the intervention arm and 20 in the control arm. For the actual intervention, we hope to invite them to seminars, but also to give them a leaflet with information on all the different wellbeing resources that are already available, whether these be locally at the hospital or the different bladder cancer charities. So in the UK, we have Action Bladder Cancer UK and Fight Bladder Cancer UK. And also within this leaflet would give them access to a website with additional wellbeing resources. And it's hoped that if they do use the website, we can sort of track where the traffic is highest on this website to see which aspects they're looking at and using. For study endpoints, so the main endpoint is the feasibility and adherence to the services already offered. The patients who take part in the Graham-Roberts study complete a questionnaire at baseline and then annually thereafter. So the other endpoints will be collected using these questionnaires, and these include health-related quality of life, fatigue, depression, physical activity, dietary habits, and sexual well-being. They'll also complete an evaluation form after 1 year of follow-up to see how the intervention is going. So unfortunately, due to COVID, the actually implementation of the feasibility trial is being put on hold. And so it's hoped that in the near future, we can get some funding to actually run this feasibility trial at Guy's. So that's the article. If anyone would like to have a further look for more information, and the references also. Thank you.
Oops. Thank you so much. I really felt I could ask you 100 questions now, but I suppose I have to wait like the rest of the panel. Anyhow, thank you for an interesting presentation here, Beth. Now we will move on to Line Noos Lydum, who is Danish like I am, and she's from Copenhagen Hospital. And Line, you're a PhD student, and you will try to investigate how prehabilitation will risk reduction, will reduce the risk for patient undergoing cancer treatment. Yes. Can you
I will share my screen. I have.
Can you? Okay.
Oh, yeah.
Excellent.
Sorry. Patient's experience with patient involvement in major cancer surgery, and actually I'm going to twist this title a bit because I'm going to talk about this from the point of view of the research that I'm involved with, which is prehabilitation research, as you said, Bente. I'm going to talk about patients' experience in participating in prehabilitation studies. So I have no conflicts of interest. So prehabilitation, you probably know, but it can be defined as the process of enhancing an individual's functional capacity before scheduled surgery. And prehabilitation interventions may include one or more of these components. Most often you see physical exercise or training interventions, may be supplemented by a nutritional intervention or psychological intervention, but also components such as sexual health, stoma care, and shared decision-making, or maybe interventions aimed at risk reduction or risky lifestyle factors such as smoking and alcohol use. So in the research group that I'm working in, we are developing and testing a multimodal intensive intervention aimed at physical inactivity, overweight or malnutrition, smoking, and alcohol use. And we are doing this in the Strong for Surgery, Strong for Life study, where we try to compare the efficacy of an integrated STRONG program. This is what we call our intervention, the STRONG program, with standard care and preoperative risk reduction. So my area of this research project is to conduct nested interviews with participating patients, exploring the patient experience of being involved in the STRONG program, but also the perspective of patients, relatives, and health professionals. So why investigate prehabilitation from the perspective of the patients? This might enrich the data that we get from the quantitative prehabilitation study. It might show us how to create optimal conditions for prehabilitation, but also give us some insights for improving adherence to the intervention. And this will all help us in a future implementation of the prehabilitation interventions. So we are using qualitative methods. We're using semi-structured interviews, which will provide an insight into the experiences, feelings, and thoughts on a personal level of the patients. So in our study, we are also going to include perspectives from the healthcare professionals and the relatives. And we're doing this because among healthcare professionals, some studies have shown, and also experience have shown, that there might be some barriers or misconceptions about talking to patients about risky lifestyle factors. Healthcare professionals might think that it's unwanted by the patient, these interventions, or to talk to patients about intervening on unhealthy lifestyles. Or they might think that talking to patients about these areas might imply judgment, and they think it might harm the communication or the trust they have with the patient. And as lifestyles, risky lifestyles, are often embedded in our social life, we are also going to include the relatives in our investigations, because the relatives can be both supportive or the converse of these interventions. But for this talk, I'm going to focus on the patient perspective. So I would love to be able to present my own research for you, but we are only just starting. So I have no data to share. So instead, I've looked into other prehabilitation studies where you have a quantitative intervention that is being tested either for feasibility or efficacy. You have nested interview studies investigating the perspectives of patients participating in these trials. 3 studies are testing exercise interventions, intensive exercise interventions, and 1 study is investigating an intensive smoking and or alcohol cessation intervention. This study is from our own research group conducted by and as you can see, they're all aimed at physical improvement of the patients prior to surgery. So this is the key themes that the interview studies, the nested interview studies investigating the experiences of patients participating in the quantitative studies. And I'm not going to go into all of these findings. I'm going to focus on the psychosocial elements that come across in these interview studies, since it's the topic of this evening. So the experience of participating in a prehabilitation intervention for the patient is described as doing something for yourself. It's something positive to do or focus on before surgery in the period between diagnosis and treatment. It can give a sense of control and an ability to take an active role in a period of time that might seem out of control. It can provide an extra source of support in the cancer pathway. It can give you a sense of direction and purpose, and help you to cope with worries and feel mentally prepared for surgery. For the interventions that are group-based, the patients experience a benefit of being part of a peer group. They can develop feelings of camaraderie and companionship, and it can allow them to draw strength from shared experiences. And also being part of a group can improve adherence by installing a sense of obligation to attend, to not let the other participants down. And across all the 4 studies, it shows that it seems an important benefit for patients is that they develop a relationship with and support from the instructor. And that is also something that we see in our experience in conducting these prehabilitation interventions, that the patient seems to have a privileged access to healthcare professionals that can help them to answer questions or talk about things that are not only directly related to the intervention they are receiving. So just to finish up, actually, I've looked a bit at facilitators for adhering to these interventions, because of course these interventions are taking place in a period of time where the patients have maybe a lot of symptoms, as we've heard. They are worried about their upcoming surgery. They have a lot of appointments they have to go to. So they have a lot of other things going on besides these interventions. So it seems important for making these interventions successful that there should be scheduled appointments, but the patient should also be able to reschedule. So really there needs to be both structure but also flexibility in the design of the intervention. It's important that you time the meetings with the patients fit with their time schedule. The person conducting the intervention needs to be empathic and have a non-paternalistic approach. And also for the patients, it's important to be provided with feedback of performance and progress, to have some objective measurements they can compare themselves to. So, so this is actually all I have to say. I hope it's given a bit of insight into the experience of participating in a prehabilitation intervention. And what I hope is come across is that these interventions, though being aimed at physical improvement for the patients, are actually also, as for the patients, experienced as something that contributes to or is a kind of psychosocial support for them in the period while they're waiting for their surgery. And it seems to be meaningful for the patients to participate in these interventions. And therefore, maybe as healthcare professionals, we shouldn't be that worried about asking the patients to participate, because it is meaningful for them. So that's all. This is just the references. Thank you.
Excellent, Line. Thank you for a nice presentation. So now we move on to the floor. We have a few questions, and please go ahead and fill in the Q&A section. Now you have a really good chance to ask the experts for the next couple of minutes. We have a question from Suzanne, actually my colleague from Copenhagen. She says, thank you, Nihal, for a great presentation. What intervention support do you suggest to respond to the unmet needs?
Thank you, Susanna. That's a great question. And I was just thinking about that. I think it depends on the type of the needs reported. If you're thinking about the psychosocial needs requiring psychological support, such as depression and anxiety, similar to what I have shown today, that depends on the level of the depression and anxiety experience. So if the symptoms meet the criteria for clinically significant levels, then that requires immediate attention from a social worker or a psychiatrist to treat patients right away by providing medication or psychological consultation and other different support resources needed for these specific patients. If they are borderline or reporting lower levels of depression and anxiety, then you need to provide some preventive strategies to help them really cope with bladder cancer treatment outcomes, such as improving diet and nutrition, relaxation therapy, mindfulness, and meditation or yoga. So that would be my advice for this specific unmet needs. If you're thinking about informational unmet needs or sexuality unmet needs or other needs in different area, then you need to tailor the resources available, whether in the hospital or online, to these specific needs that patients are sharing. Thank you.
But then I have a question myself, because I know from Elke's PhD and her studies, she says that it's nice we have the resources maybe in-house, but what are we doing if we can't motivate the patient to use or apply for these resources? Elke, can you give an answer to that?
That's a very good question. I think so. In our studies, it was often the case that people were just not aware of those tools, and if they are just provided with the information about the availability of the tools, and also, which is very important, if their healthcare professional just says this can help you for this reason, then they will be more, I think, willing to use or more interested to use those resources, because that's also the same for physical activity, for example. If the clinician tells the patient that would be very good for your outcomes, then we see that patients are more willing to engage in such interventions.
So the professionals should be more keen on motivating the patients.
Yes, but then I think there's a need for better self-management tools as well. Maybe e-health interventions can help in the future, but I think this might be the way to go, but there is still a lot of work in this area of e-health to really come up with a tool, with an app for a website, to support patients in their self-management and to take an active role in their own pathway.
I know I have been asking you before, but how do we motivate patients on 74 years old, for example? The ladies from King's College show that they have an average age on 74 in their cohort studies. How do we motivate people on 74 to apply for psychosocial help? I know it's a difficult question.
I don't know in the psychosocial interventions if I don't know the difference. No, it's true. We see that for example, younger women are more willing to go to psychosocial services. I think it's I think it's the same answer. We need self-management tools, but we really need to know, to understand how we can provide them with the best self-management help. And I'm not sure. I think it's also important to just explain everything very well to those patients. Sometimes it's just sitting with the patient. Clinical nurse, for example, has a key role in this aspect to just really explain everything well, and also to engage or to engage the family of the patient, that family members are also aware of everything that happens, everything that is available, because sometimes for the patient it can be a lot to process. For example, at timing of diagnosis, the patient receives a lot of information, which can be very overwhelming. And then if you if you make sure that the family members are the important people in the patient's lives, are also aware and are also provided with the correct and relevant information, and maybe social support in that way can also help them to
Okay, excellent.
Just an idea.
But I know it's a difficult question, but that's the question we all want to know the answer of. So, of course, I don't expect you to be able to. Robert McCongley, you have asked and noticed that BC patients are 5 times more likely to be diagnosed with mental health problems. And you ask, is there breakdown between MIBC and non-muscle invasive bladder cancer? Can anybody answer that question?
I can give it a go. So in the studies that I've looked at, it tends to be that the studies either just look at non-muscle invasive patients or look at the muscle invasive patients, and there doesn't seem to be much comparison across stages in the papers. So it is actually quite hard to compare the figures. And I've noticed in one of your other questions, you noted that most of the studies do seem to focus on muscle invasive bladder cancer patients, and particularly patients who have radical cystectomy. So I think it is probably quite an under-researched area, looking at the mental well-being of those non-muscle invasive patients who do also have different sort of anxiety with the regular flexible cystoscopies they undergo.
Okay. And Anna, now when we're in this area, you also said that there's a high prevalence of suicide among these patients. Mm-hmm. This is really shocking, and I think it's a great initiative you have made at your own institution. But how can we possibly address this knowledge? I mean, what should we do as in clinical practice to address this knowledge?
That's a very difficult question. But one of the things that was noted in that cohort study, that the median time for suicide was very long for bladder cancer patients. So it was up to about 1,000 days compared to, I think, in the hundreds for sort of like prostate cancer, kidney cancer.
Right. Okay.
So it shows that bladder cancer patients, so this was looking at post-radical cystectomy patients, do experience that psychological distress for a long time. And maybe, as Elke was saying, at that time of diagnosis, there's a lot of information to take in. Maybe their psychological well-being is not at the forefront. So maybe during the yearly follow-ups, it's important for the clinicians to check in at that point at their well-being. And especially if they're men of the older age, they might not be very forthcoming about their struggles. So clinician prompted regularly, I guess.
And Anna, there's another question for you. Do you offer counseling for all newly diagnosed patients at Guy's?
So actually at Guy's, we do have quite a well-established counselling and psychotherapy centre. So all newly diagnosed bladder cancer patients sit down with a clinical nurse specialist, and they go through a holistic needs assessment, and there they can list their concerns. So that can be anything from like emotional, physical, financial, and at that point, if they do highlight any emotional concerns, then the clinical nurse specialist can show them, point them to the right direction for the psychotherapy. So they have to self-refer, but the clinical nurse specialist will pick that up and can kind of keep following up to make sure that they do get in touch with the psychotherapy service.
So they need to cross the barrier anyhow and ask a clinical nurse specialist for support.
Well, so the clinical nurse specialist goes, they have to be honest with the clinical nurse specialist about their issues.
And Nihal, what is the situation at Mount Sinai at the moment? Do you screen for mental health problems, and do you offer them proactive counseling?
So that's a very good question, Bente. We do that as part of our research study, but we're not sure if the physicians are compliant with these recommendations we made to them. So unless a patient brings this topic during a consultation that they need assistance with depression and anxiety, or experience higher levels of anxiety and depression, the physician will not refer them to the Department of Social Work or Psychiatry. And this is something that we have been concerned about. That's why we're pushing for these educational materials to be used by our physicians and nurses in the Department of Urology.
And some of you also mention sexual problems, especially in women. It's totally underreported. And how do we, is there any recommendation for how we can, as professionals, address this issue? Because we all know it's underreported. Are you screening for sexual problems in the early phase? I mean, preoperative? Any of you?
Well, from our experience at Sinai, that's another area that patients are not typically open to share with their physicians, even if they experience sexual dysfunction related issues after treatment. They wouldn't be open to discuss.
But I noticed in one of your studies, actually, you're one of the first ones to address that the women actually would have preferred to be asked in the preoperative period about sexual issues they may expect to have postoperatively. So
that is correct.
I know it's one of the studies from 2014 or something like this. I wonder if you have addressed that later on.
Unfortunately, till this point, we didn't have like a standard screening measures to help patients communicate about these issues during the consultation. We hope that this will be something we could cover in the future. But sexual function is a major issue for both male and female patients.
Yeah. What is your experience, Anne and Beth, in London?
So, I mean, I'm not clinical, so my sort of only experience is from the results from the discussion groups, but yeah, very similar to what's been discussed, is it seems to be the females that are sort of more affected. So we have an erectile dysfunction clinic for the men at Guy's, and obviously, you know, we don't have an equivalent for the women. I don't know if, you know, putting on another clinic puts on a lot of burden to, you know, the already very busy clinic. So I don't know if that would be an option, but certainly, I guess, aiming to point patients in the right direction of support that they can receive. And I'm sure the charities have things that, you know, they have in that aspect as well, that we can point them in that direction.
But I think that's the picture across the US and also across Europe, that there are also always a clinic for erectile dysfunction, but there's very few clinics for sexual health for women after surgery. So I think that's something we have to take up in the future, as also for both researchers and nurse specialists. Is there any more questions? You have an excellent chance now to ask the experts, so bring it on. So Line, I have a question for you, if you don't mind. You say, don't be afraid to involve the patient, don't be afraid to ask them. Can you elaborate a bit on this? Because I think that's also some of the barriers. Actually, clinical staff also have barriers to ask questions because we may be afraid to overstep some boundaries. What is your experience regarding this?
Well, my experience from the research studies, the patients don't mind being asked, they don't mind talking to us about these risk factors. They might not want to participate in our research, but they don't mind talking to us about it. So, and from the studies, we can see that they do find it meaningful, and that's also my experience. They do find it meaningful to participate in interventions. Yeah.
Okay, so we should ask them more and involve them more. or what?
Yeah, they will let us know when they don't want to be involved. Yeah.
Yes. Okay. Thank you so much. I'd like to thank all the speakers for participating tonight. Psychosocial care is definitely a very underreported area of care to bladder cancer patients. So it's really most appreciated that you participated tonight and contribute with all your experience and evidence-based knowledge on this subject, because this is really underreported field, as I said before. So thank you so much for participating, and I hope that the audience have enjoyed the experts' perspective on psychosocial care tonight. So thank you very much.